Welcome to More Than Dentistry, where your hosts Evert and Waldo discuss life, dentistry, and everything in between with dentists around the world.
Hello and welcome to the More Than Dentistry podcast.
Thank you and welcome to More Than Dentistry podcast. It's an honor to meet Sonia Chopra, an endodontist from North Carolina in Charlotte. Is that correct?
That's correct. Thank you so much. I'm glad to chat with you today.
Okay, great. So tell me, Sonia, how did you become an endodontist?
So I think I was born to be a dentist.
Okay.
I was born with a lot of congenitally missing teeth.
Yes.
So that kind of just put me in the dental chair all the time.
Mm-hmm.
And so I was missing my maxillary laterals, my mandibular second bicuspids, and my wisdom teeth. And before I went to college, so it was the summer right after I graduated high school, my mom was adamant on, just restoring my occlusion and, before she shipped me off. So I got 2 bridges on the bottom.
Yes.
At the time, it was 1995, so I wasn't really offered implants. And then soon after I got my restorations, I started developing some pain. And I couldn't exactly pinpoint it. It wasn't localized. I would say the saga kind of like dragged out for about 9 months, where I was back and forth from college with a pain that nobody could diagnose. The dentist would look at me and say there's nothing wrong. The x-ray showed nothing. He did some tests and couldn't pinpoint it. And finally he sent me just to take one of my teeth out. And my mom, she's a physician, but she didn't really understand the process. And so she just kind of went along with it. And so I had a tooth extracted. And after the anesthesia wore off, I still had the same toothache.
Oh, shame.
Yeah. So for me already missing 8 teeth and now there's a 9th gone, that was really devastating to me. So I'm very sensitive to diagnosis. But then I was finally referred to an endodontist.
Okay.
And that's when, I was referred to one and he gave up on me, and then I was referred to another one who was the coolest guy on the planet. He was so patient with me. He explained everything from A to Z, and his whole demeanor captivated me. And I really, as a young child, I was 17, I could understand everything. And I always had a medical influence. My mom and my brother are both physicians.
Okay.
But I knew I wanted to do something in medicine, but I really didn't want to be on call like my mom always was. So I kind of steered myself into dentistry. And then I found myself just really, again, captivated by endo and trying to figure out my own story throughout as I was learning in dental school. And it kind of just landed me in endo. I gave general dentistry a shot. I did a general practice residency in Brooklyn, New York, and then I worked as a general dentist in New York City for a couple of years. But my heart just kept on gravitating to endo. So that's how I became an endodontist.
Wow, that's great. I must say, in South Africa we don't have an endodontic specialization per se. So most general practitioners do endodontics. And we have good guys that are really, really good at endo. That they could possibly just be an endodontist. Yeah. They've limited their practice to endodontics.
I think that's wonderful.
And it's just, it's nice to just see what it looks like on the other side of the world. From how you guys are doing this and how guys are referring you patients and just specializing in endo. Tell me a little bit more about yourself when you down your tools at the end of the day. What do you do? What's at home? That kind of thing.
Well, as soon as I put my handpiece down, I'm off to run back to my family. I have a wonderful husband and I have 3 lovely children. I have 2 girls and a boy. I think kind of the flip of you. You have
Yes.
2 boys and a girl? Yeah.
That's right, yeah.
So, and my kids are a similar age to yours. I have a 9-year-old girl, almost 7-year-old girl, and a 4-year-old boy.
Yeah, I think our spacing is more or less the same.
Yeah. So, our hands are full there, but I love to travel with my family, probably first and foremost, and teach them through experiences.
Awesome.
I'm a little bit of a foodie, so that's
lovely.
part of my fun stuff. And then I just love to hang out with friends and grow myself spiritually and personally.
Okay, cool. And what's your greatest place that you've been traveling to? Your favorite place?
Oh gosh, I don't know if I can pick one because I've been all over. I love Thailand. Greece has been amazing, Bora Bora, and I just recently went to Croatia this past summer for a month. So
wow, that's awesome.
Yeah, South Africa's on my bucket list. So.
Okay, cool. Yeah, so tell me, do you know any interesting facts about South Africa? There might be a reason that you want to come to here.
I know nothing about it, but I do want to. I don't know why, but go cage diving with the sharks.
Well, it's very popular. I don't think anyone's saying no. It's an awful idea. So, yeah, it's definitely a good thing to do.
I'll probably just stay on the boat and watch people go.
Yeah. I think the reason why we wanted to start the podcast was not just to give people an idea of about dentistry and people that we interview, but also look a little bit behind the curtain. And I think, especially in the demanding jobs that we have, there's sometimes life-changing. Well, you've definitely had a life-changing experience with the way you got to dentistry, but is there anything else that sticks out, that negative or positive, that formed how you live your life, how you practice every day?
Well, I love the name of your podcast because I think that it is way more than dentistry. And I think in order to be a successful practitioner or a successful leader, you do have to go beyond. And I don't think I learned that really early on in my practice. I'm now in my 11th year of my private practice. And it kind of took me to about year 6 to have like a wake up call. I would say the one thing that really made me realize that like I couldn't keep grinding was the birth of my first daughter. She was born with a few issues, and so she had to have multiple surgeries by the time she was 4 months old. And I knew that I couldn't keep running an endodontic practice 5 days a week by myself, and I had to make some conscious decisions. And when I started to really think about things, things started to change. And so I allowed myself a little time, for myself to reflect, to really answer those questions of what's really important to me, what do I want in my life. And I think when I ask people those questions, nobody really knows the answer. Because so many people are just, running around crazy. They're trying to be a dentist and plus a manager of their practice kind of all at the same time. And when I realized I needed to take a step back, maybe bring some other doctors into my practice so that I could have, even if it was just 1 day a week to work on the business, things started to really shift for me. I started to give myself like non-negotiable time where I could think, I could put pen to paper and start getting clarity on what I wanted in my life. And that's been a gradual shift over the past 5-6 years, 5 years, I would say. Really in the last 3 years, it's been like just growth after growth after growth, which has been great. But it took me a while to kind of have that realization of how important lifestyle was for me over the daily grind of my practice. But once I did that, the practice started to just exponentially grow.
Children definitely changes everything when they enter the world. And the other thing as well is that I think what you're almost talking about is block timing, in the sense that you're blocking off time to do certain things. Yeah. And that creates actually more time to do the other stuff that you usually do, whereas we're trying to fit in admin and practice management in between, and it doesn't work.
Right.
But when we set out the time to do it at a different time, it actually works much better.
It works much better, and you get more productive. I think a lot of people have the mindset and the belief that, oh, I have to work 5 days a week because then I'm going to make the most amount of money. But once I started consolidating my patient care time, I went from 5 days to 4 days, and I was making more in the 4 days than I was 5 days. And now I just made room for another doctor in my practice. And then when my second child came, I gave myself permission to work 3 days and again give the other doctor more time in the practice, which everybody was happy. And now I had a day to my family, a little bit of time for myself, and then a whole separate day for admin. And then again, I started to grow and shift. And now this year I work, instead of 3 8-hour days, I work 2 12-hour days. So I'm still getting the same amount of hours. But when I tell you my production is through the roof, beyond the 3 days, it's incredible.
Yeah. And that's awesome.
Yeah. So,
okay, well, let's switch gears a little bit. Let's get to the practice stuff or the clinical stuff a little bit.
Yeah.
A basic question, or I think is a basic question, is everybody asks, one-step endo or two-step endo? What is your feeling?
Well, I used to be, I love to do one visit, and I used to do pretty much everything in one visit except for emergencies, because either they were swollen or I just didn't have enough time. And then also I was a mandatory retreatment has to be two-step. But I have recently incorporated the gentle wave technology into my practice. And so now I'm about 90% one visit. And I'm seeing a lot of decrease in flare-ups. I'm also seeing the decreased need for pain medications and antibiotics. I don't know if that's because it's one step or if it's because of the gentle wave. I can't tell you that exactly.
So what is gentle?
Gentle wave? So the gentle wave is a new irrigation delivery machine.
Okay.
Basically what it does is it has a special handpiece for each patient, and you create this platform. You place the handpiece on top, and it creates a seal, and it will degas the irrigant. So it'll run sodium hypochlorite and EDTA through the handpiece and in throughout the tooth. It degases that fluid, so any of those bubbles that kind of hold up the irrigant from getting pushed towards the apex, those bubbles get sucked out, and then it uses sound waves to basically pump the irrigation through the tooth and then back through its suction.
Okay. Wow, that's very interesting.
It's really cool.
Yeah.
And
so, I've recently only started using a negative irrigation system, which is very laborsome, but it works at this stage. So.
Yeah, anything that can amplify your syringe irrigation, I think, is great. So I haven't really altered my procedure that much. I use this as an adjunct right now. Okay. So, I haven't really replaced anything just yet. I've just added it on to my current procedure that I was doing for 10 years.
Okay, and then how much time do you probably irrigate the whole time, but
it runs for about 7 minutes.
Okay.
And so I don't really have to do too much irrigation other than that. And I instrument to an F1 Pro taper, and then I'm done, because it allows you to do minimal instrumentation.
Okay.
And so that part is a little bit quicker. You run that for 7 minutes and then you're ready to obturate.
Sure. Wow, that's fantastic.
Yeah. So it's shifted my practice from 50% 2 visits to about 90% 1 visit.
Mm-hmm.
And the only ones that really take me 2 visits are if they're really draining and I can't dry the canal, or if it's just really calcified and it's hard for me to negotiate the canal and achieve patency. So then I kind of, I let it soak in some calcium hydroxide and I bring it back another day, and then I typically am able to obturate then.
Okay. Yeah, that's probably the other thing is difficult cases. What's your go-to for, let's say, calcified canals, except just having good long patience to get through? But you say just leave it a little bit with sodium hypochlorite and wait a little bit.
I will actually use EDTA, liquid EDTA in that case. And I would use 21 millimeter C files, starting with like a size 6 and size 8. And sometimes I can really go through like half a cup full. But it's a lot of just pecking away with the EDTA. And those are some instances where I use RC prep. I don't use it that often, but I'll use it in those cases. I also hook my C file onto the M4 handpiece, and it'll turn my hand file kind of into a reciprocating rotary file, and it'll prevent me from getting like too much hand fatigue, and then it'll get me patent. So I'm a big believer in patency, especially when there's a lesion and when there's percussion tenderness. I'm a huge advocate for patency. So I don't stop until I'm patent.
Okay, cool. What about file separation? I'm sure as an endodontist, it's probably something that you get into your office quite a few times from a general practitioner. What's the best way to not to treat this, but to handle a situation like that?
Well, I typically bypass. I'm not the best remover of them because we don't see them that often. Luckily, our practice doesn't see them that often. But I would say the best luck I have is when I bypass. And again, you kind of treat that like a calcified canal. You start with a 6C file and you kind of wedge it in there and kind of work it, and then you make it a little bit bigger, and eventually you can instrument around it. And if that doesn't work and an apico is favorable in that situation, sometimes you have to do an apico. And these are really like the ones that are in the apical third. If things are in the middle or the coronal third, then obviously we'll try to use an ultrasonic to remove it. But for the most part, I'm a bypass girl. I like to just get around it instead of removing too much tooth structure just to get it out.
And that can be quite destructive at the end of the day.
Yeah, actually the gentle wave has helped me a lot in those cases because the irrigation kind of breaks it up and loosens the file, and I'm able to bypass it a lot easier once I run the gentle wave. Yeah.
Okay. When would you really, you never really want to remove a tooth, but when would you say this tooth is not destined for endodontics?
So I've been getting a little bit better at, that preoperative discussion with the patients when I can kind of predict a cracked tooth. And so when I see that shallow amalgam on that mandibular second molar and there's no other reason why that tooth should be necrotic, you know that there's a crack in there somewhere that's being a doorway for that bacteria to get in. So I have a discussion with the patient like, hey, I know you have a crack in your tooth, and if it's contained to this wall, like that, and doesn't go into the root, your tooth is fine. If it's contained to the other wall and doesn't go into the root, it's fine. But the moment I see those two cracks joining across the floor, then I know it's about to become a split tooth and need to be extracted. So if I see that with my microscope and I'm examining the chamber floor, or if I see a crack that goes all the way down, like a distal marginal ridge and into the root, those aren't the most, favorable prognoses. So that's when I have the discussion with the patient that you probably should take the tooth out. But I don't mind saving perforations. I have saved plenty of resorptions. There's not that many teeth that I give up on. I always say give teeth a chance. So there's a lot of stuff that we can save that I think that a lot of people don't realize what we really can do, that we don't even consider heroic.
Wow, okay, great. But what about, I've heard the term the other day, a prophylactic root canal in patients where there's secondary dentine that's laying down, and they said they should maybe, before you consider crowning the tooth, maybe consider doing a root canal. Is that something that you subscribe to?
I think that is a case-by-case decision. You know, some people, I have a lot of patients who are actually afraid of doing a crown without doing the root canal because of past experiences. But I think there's a methodology in which you can do that, you know, put them in the temporary crown, see how they do. And then if they're symptom-free, then you can move forward with the crown. You know, sometimes you know that you're going to have like a short prep, and so you need a little bit more of a prep to get retention of your crown, and you're going to go into the root canal, and you need to do elective endo. So I think there's a place for it, but you know, I don't need to root canal everything, so if I can avoid it too, I will.
Yeah. What about pulpotomies on primary teeth? Is that something that comes into your practice? And how do you go about doing your pulpotomies, if you do?
Sure. Actually, I just wrote a blog about it. It's going to be coming out this week or next week. Okay, cool. And really I don't get a lot of those in my practice. I have some friends who are kind of like the pediatric endodontists, and they will do the pulpotomy, and they will use calcium hydroxide for, you know, a week or two until the infection is cleared up, and then they'll obturate the tooth with MTA and allow that tooth to naturally exfoliate so that they don't have to use a space maintainer.
Okay.
So it's absolutely possible. But I don't see that a lot in my practice. I usually get the permanent teeth that need the MTA pulpotomy.
Do you then just do a full pulpotomy, or like when it's just exposure?
Yeah, I try to leave as much coronal pulp as I can. Sometimes I've had to remove the entire coronal pulp, but if I can just kind of limit it to a speck and just remove like 2 millimeters of the pulp and then place the MTA on top of that, just so we can have further root formation, then I prefer to do that. And those we do quite a bit. Okay.
So let's talk a little bit about tools and stuff that you use. I've recently, my one colleague in practice said she'll never wear dental loops. She can't think that she'll handle the stuff on her face. And why do I need to see so much? And I said, well, just hang on. And I phoned the one rep, and I asked him, well, maybe can she just try out the loops and see what she thinks? And I think it was like 2 days, and she was sold. And the same time I said, well, maybe just come and, if you have a demo microscope, maybe just come and put it in the practice. Let me just see if I can work with it. And now I can't work without it.
I know, I saw that. How long have you had it?
I've had it now for 3 weeks, I think.
It's incredible, isn't it?
Yeah.
It's incredible.
It's amazing. Yeah, I mean, from crown and bridge to the small surgery stuff and the endodontics, it's mind-blowing.
Yeah, it's a game changer. Like I can't even do a tooth number 8 without my microscope.
Yeah.
There's so much to see, and I'm the type of person, if I can't see it, I can't treat it. So.
Yeah, no, that's absolutely true. I must say, just the amount of vision that you have and not straining, and it took a little bit longer initially but it's totally worth it. That's for sure.
And you'll keep developing more and more speed. And then it'll make you faster. It'll flip to the other side. It'll make you faster. Because you're not fighting with the tooth anymore. You can see it. Yeah.
But what's your other go-to things to use in your practice?
It's definitely
Except just for our rotary files, I presume.
It's my cone beam. I cannot live or practice without my cone beam. It really has been an eye-opener for me, especially when, you just don't know what's wrong with the tooth when you're just looking at the radiograph and you're listening to your patient's symptoms. Before, because I grew up without the cone beam, right? Just like I grew up without my cell phone, I grew up without my GPS, and now I'm lucky that I get to use all these fun things, but I'm glad that I grew up with the traditional diagnostics, so I think that's really special. But when you can couple that with your cone beam and mesh the two together and get that diagnostic synergy, that's where the magic really happens. Because there's so much in your cone beam that you can misinterpret. I want to put it out there that people think that they can find cracks with their cone beam, and you can't. You can find a lot of artifact with your cone beam, but you can't really find the crack. And so I hope that we're not over misdiagnosing cracked teeth because of the cone beam, because you really can't see them unless it's flat out really fractured, but then you can see that on the radiograph. So the cone beam to me tells the whole tooth story, and then I can use that as an education tool to my patient and show them, like, your tooth is not functioning, your root canal is not functioning because there's another canal that hasn't been treated. So this 10-year-old root canal has a 10-year-old infection in your body, and it's now starting to flare up, and this is how I'm going to improve this root canal, because most people are like, well, if one root canal didn't work for me, why is the next going to work for me? So it's been a really great educating tool, and it's really helped me have just a more predictable outcome and a more confident conversation with my patient.
Yeah. I've had a strange case just the other day where I've had a patient come in and say she's just been to this other specialist, and she has fibromyalgia, and they decided to take out all her root canal teeth. In any case, there's people that believe in this stuff. What is your, what would you say to a patient like that when they walk into your practice?
Well, typically I show them like a success story. I show them a patient with a tremendous infection with a lot of bone resorption, and I show them what happens after you do the root canal properly, and I show them the bony regeneration. And that right there gives them a little bit of a mindset shift. They realize, like, oh, wow, like, this can happen. And I say, yeah, without a bone graft, without anything. And I think that there may be other issues, maybe it's the food that they're eating, maybe they don't eat organic. I don't know what it is, but I have this conversation a lot because people feel like there's still bacteria in their tooth, and that bacteria is what's causing all these other issues. And, I kind of tell them, I said, you know what, nothing is ever going to be 100% bacteria free. Not the food that you dropped on your dinner table, that dinner table is dirty. You cleaned it, but it's still got something on there, and you picked up your food and you ate it, and not all bacteria is bad either. So who's to say that some of the bacteria is bad? So perhaps some people will have a different susceptibility to things than others. And so is there a potential for this? Absolutely. But I think some of the claims that are being put out into the media are extremely false, and there's no documented science that is really available. There's no, you can't say correlation is causation for sure.
Yes.
And I think you just need to be careful about fake news as well. So, I think there's a few points to hit when talking to people. And once I have these conversations and I kind of show them the evidence from other patients, they actually kind of change their mind, and maybe there's a different source to their fibromyalgia and not their teeth.
You have your own website, soniachopradds.com. Is
That's
that
correct.
right?
Yeah. Yep, that's correct. Sonia with an I.
For helping dentists becoming more proficient in endodontics. Please tell us a little bit about what's your course like, for who is it, and
Yeah, so I think in the 10 years that I've been in private practice, I have seen my own tooth story come into my practice over and over again. And so to me, that was a sign that we just didn't have enough time to learn it all in dental school. I don't know what it's like where you're from, but in the United States, I only had to do 4 root canals before I graduated, and I basically got a crash course in it for 2 weeks when I was a second year dental student. And that's really not enough, because if you ask me, endo is really the basis of dentistry. 80% of patients seek us out because they're in pain, and diagnosis is the key to success. And endo to me is diagnosis, it's pain management, it's emergency care, it's cracked tooth, it's vertical root fracture, it's trauma, it's resorption, it's cone beam, it's all of that all in one. And it's not just doing the root canal, because people who are like, oh, I don't need that course because I don't do any endo in my practice. I'm like, you're silly, because you do endo all the time and you don't even realize it. Endo is all the way throughout dentistry. And I also volunteer my time at the local GPR in my town, and I see the way these students are graduating, and they don't know how to do a pulpal or periapical diagnosis. They don't know how to perform diagnostic tests, and I don't want patients to end up the way I did. So like I said, I'm very sensitive to that topic, and so I was like, how can I help? Why does my practice, why is it 50% retreats? Why am I doing so many retreats? And can we change that? Can we decrease the number of retreats in the world? And I truly, truly believe that we can. And then I think people could actually take that extra money and go on a lovely vacation instead. So the course it's an online program, so anybody in the world can take it. It is in English, so hopefully your primary language is English, or you understand it, English a little bit. It's full of videos and downloads. So there's downloads to complement the videos. So if the things that I use in my practice, like the evaluation protocol or whatever, you can copy and paste it, put it in your practice management software. You can easily train your team to make this your normal protocol in your practice. So it's really meant for anybody, whether you are a recent graduate and you really feel like you just didn't learn enough, it's for you. If you are an associate in a practice where you're expected to do the endo for the practice, it's definitely for you. Or maybe you're a practice owner and you want to incorporate endo into your practice. Or even if you don't do endo, it's for you, because there's so much more than just doing the endo. And then maybe I've had a lot of seasoned dentists take the course too, because they just wanted to get those little tiny tips and tweaks and tricks that they can implement into their practice to really get really good. So there's all the stuff is available online on any device at any time. You can watch it. And then 2 times a year I offer a coaching version where you actually get access to me and we can troubleshoot your specific problems. So we can, stop running into those things in your practice. And so the idea is it's to decrease your chair time, decrease the refunds you have to give to patients, and also to increase those happy patients and those happy reviews, and to save a ton of teeth. So
where we have a need in South Africa is usually our graduates go from dental school, and then you do community service here in government. And that's where it becomes quite rural, and that's where they unfortunately just
Right.
take out a bunch of teeth.
Right.
And they lose some of the skills that they've actually acquired at dental school. Because
Sure.
I must say that our endodontic program in the dental schools, or when I was still there, was actually was quite extensive. I think we had good diagnostic skills and we had to do quite a bit of work. But you lose some of that in your community service. And so this might be an avenue for these guys to just brush up on these skills again.
Yeah, some programs are excellent, but to be honest, I mean, I'm just going back to how I was as a dental student.
Yeah.
Like, it was taught to me, but I don't think I was ready for the information, you know?
Yes. Yeah.
And there's something, when I took my board exam and I had to relearn everything that I learned in my residency, I really saw the value of learning things all over again after you've had some clinical experience that you can relate it to. So when you go back and relearn things, it gives you this new level of confidence that just goes back and translates so powerful in your practice. And that's when you see that dramatic growth and dramatic change.
Yeah. Okay.
So,
thank you for making a positive change. I think that's so important. People like to complain about a lot of things, but people stepping up and making a change where they see that there is a need, that's always good. So thanks for that.
Yeah, no problem. I love it.
Yeah. Tell me, where can people find you on social media? Where are you the most active? And
Yeah, so you can find me on Instagram at Sonia Chopra DDS. That's Sonia with an I. At Sonia Chopra DDS, that's Instagram. You can also find me on Facebook at Sonia Chopra DDS Endo for All. And my website, which is soniachopradds.com.
Yeah. I've actually downloaded some of the online forms and so on. It's really helpful, and I think that's definitely something that I'll implement in my practice.
That's awesome. Thank you.
Yeah, well, thank you very much for the chat.
Yes, thanks. This was amazing.
Yeah. Okay. Well, keep well, and we'll stay in touch.
Okay, absolutely. I'll see you.
Okay. Thanks, bye.
Bye-bye.